Hello everyone, this is Professor Sorabi wishing you all a safe and healthy life at this current moment. As we promised, we're going to provide you Mobility 2 lecture with a voiceover. So I'm trying. This is not easy for me to talk to myself while I don't have you in front of me. You are so encouraging and you make me feel so good when I teach. But right now, no, I don't have any other choice. Not seeing you, which is a joy to see you all when we teach. Anyway, we're going to talk about the management of patients with mobility disorder, musculoskeletal trauma. And we know that unintentional injury is the fourth leading cause of death in the United States. Unintentional injuries are commonly called accidents. However, this term is considered inaccurate by trauma professionals. The term accident infers that there is no potential for prevention, but healthcare professionals understand that prevention plays a major role in decreasing the rate of injuries. The implementation or intervention of evidence-based primary prevention policies may prevent many unintentional injuries from happening, just like following the policies or regulation or rules of driving, right? So the fracture injuries account for more than 1 million hospital discharge in the United States. Therefore, nurses who work in emergency department, critical care units, and inpatient medical surgical unit frequently encounter patients who have experienced musculoskeletal trauma. However, upon discharge from the hospital, many of these patients require an extensive period of rehabilitation and follow-up. Therefore, nurses who work in rehabilitation centers, long-term care facilities, ambulatory surgery centers, occupational health setting, and primary care clinics may all care for patient with musculoskeletal injury. Okay, as we move on, we already covered some traumas from the chapter 42, including contusion, strain and sprains, and amputation. What we are going to cover in this session is the fractures, care, management, treatment, and nursing management for fracture, and all the other modalities that we can care for a fracture, and also possible complications and nursing care or preventive measures, monitoring the patient for possible complication and caring for a possible complication. Please pay attention to this, which is really important for you as a future nurses to be able to identify the problems or possible problems or complications, and then have the knowledge of identification of the complication and treatment, and which sometimes the treatment are very critical and emergency. And I know many of you, when you take the test, you say, oh, we were told that we shouldn't call the physician. But in some cases, you have to, as the future nurses, to know what is emergency and when I should make a decision or a call to call a physician. Let's go over the fracture. So what is the fracture? Fracture is a break in a bone secondary to a trauma or a pathologic condition. Fractures caused by trauma are the most common type, as we said, of the bone. But the pathological fracture can be caused by metastatic cancer, osteoporosis, or Paget disease. Bone is continually going through a process of remodeling as osteoclasts release calcium from the bone and osteoblasts build up the bone. Remodeling of the bone occurs at equal rates until an individual reaches their 30s. From this age on, the activity of the osteoclast outpack the osteoblasts, increasing an individual's risk of what? Osteoporosis, yes. This process significantly increases following menopause, and subsequently, these clients or patients experience fractures secondary to osteoporosis about a decade earlier than patients who do not enter menopause. So, talking about the we live and learn, and nurses are one of the professionalism in nursing is lifelong learning, and I'm learning to just record my voice over this and playing with this type of recording. Be patient with me. All right, type of fractures. Fractures are classified by location, the degree of breakdown to the fracture, to the bone, and character of fracture and the fragments of the bone. We have different type of fracture that are graded based on the extent of the tissue injury. Type 1, which is minimal skin damage. Type 2, which is damage includes skin and muscle, and contusion, but without extensive soft tissue injury. And grade 3 is damage is extensive or excessive to skin, muscles, nerves, and blood vessels. A complete fracture goes through the entire bone and dividing it into two distinct parts. An incomplete fracture goes through part of the bone. What is a simple fracture? A simple fracture has one fracture line, while a comminuted fracture has multiple fracture lines, splitting the bone into multiple pieces. So keep that in your mind. There could be different type of fracture and how to manage the care of those fractures. We have a displaced fracture which has bone fragments that are not in alignment, and a non-displaced fracture has bone fragments that remain in alignment. There are some fatigue or stress fracture which results when excess strain occurs from the recreational and athletic activities. A pathologic or spontaneous fracture occurs to bone that is weak from a disease process, and compression fracture occurs from a loading force pressing on cancellous bone. This condition is common among older adult clients who have osteoporosis. Okay, there are many common types of fracture, which includes comminuted, which is bone is fragmented. Oblique fracture occurs at oblique angle and across the bone. A spiral fracture occurs from twisting motion. An impacted which fracture the bone is wedged inside opposite fracture fragment. And green stick fracture occurs on one side, or usually cortex, but does not extend completely through the bone. Usually, most often it happens for the children. Okay, let me see. All right. Clinical manifestation of fracture in general. So sometimes the student asking me which fracture. It doesn't matter. Any type of fracture. In all fracture type, these are the common clinical manifestation for those fractures. The first thing is pain. It is very painful, and you will see that extremity loses the function. You can see the deformity, and also if it's the limb, you can see the shortening and crepitus, muscle spasm along with the fracture, and you might observe some localized edema and ecchymosis. Okay, we're going to talk about the nursing interventions. So what we should do during an emergency situation with the fracture. As always, provide emergency care. Always maintain ABC, airway, breathing, circulations. So keep that in your mind. Monitor patient's vital signs and neurologic status. If the patient is alert oriented, is an accident, is an trauma. So you, as a nurse, want to make sure you check the patient neuro status. Then what else you need to do is stabilize the injured area, maintain proper alignment for affected extremity, and elevate the limb above the heart unless it is contraindicated, and then you can apply ice, assess for bleeding, and if there is any bleeding, apply pressure and cover open wounds with a sterile dressing. If you do not have a sterile dressing, which usually you are in a ER or people who are bringing the injured individuals having some kind of dressing, make sure that if there is no sterile dressing over the open wound, cover it with a sterile dressing, remove any clothing and jewelry near the injury. Usually what you need to do for removing the clothing is just what you want to do first. Sometimes you need to really cut the clothes because it's hard to remove it. If you need to do that, first you are going to remove the unaffected side and then cut the affected side and remove it. Keep the patient warm because the injury also can cause losing the temperature. Assess patient pain frequently and initiate and continue neurovascular check at least every hour. Prepare the patient for any immobilization procedure. Now, what we are going to talk about from now on, before we go to the surgery, there are different type of interventions that could be done to immobilize the fractured area. You can find these interventions on chapter 40 under the modifiable, what is that called? It's chapter 40, and that's the intervention that should be done to immobilize. And the first thing we need to know is to manage the musculoskeletal disorder and injuries, usually to immobilize them using a cast, a splint, brace, traction, surgery, or a combination of one or two of these treatments. The nurse must have an understanding of these modifiable modalities because of prevalence of musculoskeletal injuries and disorders in many settings, including home, office, hospital, long-term care facility, or rehabilitation facility. Patient education is essential for optimal outcomes. Nursing care is planned to maximize the effectiveness of these treatments, interventions, and to prevent potential complications associated with each of the interventions. The patient is instructed to manage care at home and how to safely resume activities. This is very important. So why we should immobilize the fractured area or injured area of the musculoskeletal? Basically, to prevent from the further injury, to promote healing and circulation, to correct the deformity. Now, there are many types of immobilization devices that we are going to cover: cast, splints, traction or closed reduction, external fixation, and internal fixation or open reduction. Closed reduction is when a pulling force, which is traction, is applied manually to realign the displaced fracture bone fragments. Once the fracture is reduced, immobilization is used to allow the bone to heal. Open reduction is when a surgical incision is made and the bone is manually aligned and kept in place with plates and screw. We talked about this, and if you guys remember in Mobility 1, we talked about the internal fixation and of the hip fractures or knee. For knee, it was because just a knee replacement, but for the hip fracture, it could be replacement or internal fixation. So that's the kind of surgery that could be done, and this is known as open reduction and internal fixation procedure, or ORF, that I talked about that to each class, ORIF, open reduction and internal fixation. So let's see what else we can talk. So basically, for each one of these immobilization intervention, we should learn about our responsibility, right? So we need to know what is my responsibility or your responsibility in the future as a nurses, what to assess. As I always mentioned and encouraged you guys to learn about the nursing process. And under the nursing process, what we do always, the first thing is assessment. So basically, in an injured area, you need to do a thorough neurovascular assessment, check for pain, that could be a continuous pain, check for the sensation, check for the temperature, check for the capillary refills, pulses, and movement. So basically, you are going to check the neuro and vascular together. So we talked about this in the previous lecture, how to check the neurovascular. It is very essential throughout immobilization. Assessment usually are performed every hours for the first 24 hours and every 1 to 4 hours after following initial trauma, or monitor the neurovascular compromise. Related to edema and or immobilization, you can use ice and elevation, or elevate the extremity with the use of analgesic should relieve the most of the pain. Assess the pain level, the location, frequency, and assess pain using a 0 to 10 pain rating scale, and have the patient describe the pain. So always use the old card to assess the pain, and use ice and elevate the extremity with the analgesic to relieve the pain. Sensation, what to do for sensation: assess for numbness or tingling of the extremity. Loss of sensation can indicate what? A nerve damage, yes. Skin temperature. Check the temperature of the affected extremity. The extremity should be warm, not cool to touch, and cool skin can indicate the decreased arterial perfusion. Press the nail beds of affected extremity until blanching occurs. Blood return should be within 3 seconds, and prolonged refill indicates that decreased arterial perfusion. Nail beds that are cyanotic can indicate venous congestion. Check the pulses. Pulses should be palpable and strong. Pulses should be equal to the unaffected extremity, and edema can make it difficult to palpate pulses. So Doppler ultrasound sonography might be required. So check the pulses bilaterally. If you cannot, for any reason, including edema, to palpate the pulses, use the Doppler ultrasound. And check the patient movement, and the patient should be able to move affected extremity in active motion. If they are not, so there should be some difficulty or problem. All right, let's see. Okay, so as we said, to immobilize an injured extremity or part of the body, we can use cast. There are two types of cast: synthetic cast or fiberglass, and the plaster of Paris cast. Well, there are these two different kinds are based on the prices usually, and some students ask me why some people use one over another. It depends on the prices and insurances and all of this. But with the synthetic fiberglass, it is lighter in weight, stronger, and it is water resistant and more durable than plaster. And the plaster of Paris cast is less costly and achieve a better mold than fiberglass. Heavier, not water resistant, take up to 24 to 72 hours to dry after application. Now, what is generally a cast? Cast is a rigid external immobilizing device that is molded to the contour of the body. Now, the cast must fit the shape of the injured limb correctly to provide the best possible support. A cast is used to immobilize a reduced fracture to correct or prevent a deformity. The most common cast material, I talked about them, it could be it is fiberglass and plaster of Paris. Generally, the joints proximal and distal to the area immobilized are included in the cast. However, with some fractures, cast construction and molding may allow movement of a joint while immobilizing a fracture. Casting is a mainstay of treatment for many fractures because of their ability to provide more complete immobilization. And as I said, talking about why we're using the Paris cast, plaster of Paris cast, it is less costly and achieve a better mold than fiberglass. However, they are very heavy. And as I said, it is taking time, 24 to 72 hours to dry. So what is the nursing intervention?
A freshly applied cast should be handled as little as possible to prevent denting and cracking. The wet plaster cast should be handled by only the palms so that indentions in the cast may be prevented. Indention can result in areas of pressure on the skin. So the cast should be exposed to circulating air to dry and supported on a firm and smooth surface. It should not be placed on a metallic surface or one with the sharp edges. If elevation is requested to reduce swelling, a cloth-covered pillow is preferred to one covered in plastic, which could retain heat and prevent drying. A wet plaster cast feels damp, appears dull and gray, sounds dull on percussion, and smells musty. The cast is dry when it feels hard and firm, has a white and shiny appearance, is resonant to percussion and odorless. To prevent skin breakdown, soft fabric can be used over any rough area of the cast that may rub against the patient's skin. Ask the patient or educate the patient, do not use any sharp objects to scratch under the cast, which can cause skin breakdown and also infection. The other immobilization intervention are splint and braces. It is used for fracture immobilization, initial treatment for fractures, simple, stable fractures, sprained tendon injuries, soft tissue injuries, and must be well padded. Braces used to provide support, control movement, and prevent additional injury. It should be fitted to various parts of the body and longer term use than splint. So let me see. So intervention for cast, splint, and brace. Before application of any of these immobilizing material, complete an assessment before application. And then let me see what I have in here. Promote healing of any injuries to tissue before application using a sterile dressing. So if the patient has any wound, an injury in the area before application of the cast, that should be taken care of. If there is an open wound, the tetanus booster, if needed, should be given. Assessment and prevention of neurovascular dysfunction or compromise of the affected extremity. As I said in the previous slide, check the pain, paralysis, poikilothermia, and paresthesia, which is included 6 P's. Do not ignore unrelieved pain. It's very important. Do not ignore any unrelieved pain. Observe for systemic sign of infection and educate the patient. Okay, continuing with the nursing intervention for a patient in a cast. After cast application, monitor neurovascular status every hour for first 24 hours. Neurovascular assessment is essential throughout immobilization. And then after that, you can monitor every 1 to 4 hours after the initial trauma to monitor neurovascular compromise related to edema and or the device by itself. Neurovascular assessment includes the
pain, right? And sensation, skin temperature, capillary refills, pulses, movement. For the pain, assess the patient pain level and frequently assess pain using the rating scale and ask the patient to describe the pain. It is very important to make sure the description of the pain and the sensation. For the sensation, assess the numbness or tingling of the extremity, and loss of sensation can indicate nerve damage. Apply ice for 24 to 48 hours after the cast is applied. Handle a plaster cast with palm. I talked about that. Elevate for 24 to 48 hours after cast application, and make sure that the cast is not too tight. So, educating a patient on the cast. I am so interesting. I was all over and I don't know why I used my. Okay, so well, I'm sorry that I'm taking my time to do this. All right. So educate the patient to exercise on affected extremities, and the other joints that are free from cast should be moved as much as possible. So range of motion to other extremity, to other joints are important. Educate the patient, do not scratch or stick anything under the cast, do not insert any foreign object inside the cast, and if the edges of the cast are painful, cushion them, cover the cast with plastic when needed, intact with the water. So if, for example, what you can tell the patient, if they are taking a shower, they need to cover it with the plastic. Sign and symptom that the patient should report should be educated, and persistent pain or swelling, changes in sensation, movement, skin color or temperature, sign of infection or pressure area should be reported. Report any changes in mobility. The patient should report it and require follow-up care. And for the cast removal, make sure to educate the patient for this. So we're talking about the nursing management and patient potential for potential complications. So what are the complications for the cast, splint, and braces? Because we're going to cover the same type of complication, not totally similar or different, but compartment syndrome can occur with the cast, and a fracture by itself at the same time of the fracture or after the fracture. Maybe a few hours after the fracture, or using other immobilization devices. So the first complication I would like to talk about that is compartment syndrome, which is the most common complication of casting and splint. Tight or rigid cast splint can cause constriction, and how we should diagnose this compartment syndrome is using 6 P's. The pain is earliest indicator of compartment syndrome. I would like to talk about the compartment syndrome by itself, because I had a couple questions about the compartment syndrome. What is exactly happening when there is a compartment syndrome? Compartment syndrome usually affects the extremities and occurs when pressure within one or more of the muscle compartments which are covered with fascia compromises circulation and resulting in an ischemia, edema cycle. Increased edema causes pressure on the nerve ending, resulting in pain, and blood flow is further reduced and ischemia persists, resulting in compromised neurovascular status. Pressure can result from external sources, including a cast or a constrictive bulky dressing. An internal source of the compartment syndrome is an accumulation of blood or fluid within the muscle compartment, which can cause pressure as well. So the compartment syndrome is edema causing pressure to the nerve ending, which result in pain. Therefore, the pain is the earliest indicator. Too much pressure over the nerve ending. The second, so let's go to the manifestation, which I talked about the pain as the earliest, but what are the other manifestations as 6 P's are pain, paralysis, paresthesia, pallor, and pulselessness, and poikilothermia. Poikilothermia usually occurs after the cast, but not related to other immobilization device. So pain is the earliest, and as soon as the nurse checks the 6 P's and identifies the problem as a compartment syndrome, the primary provider must be notified immediately. So let me go over the other complications that can occur after the cast. Could be pressure ulcer. The application of cast or splint can put pressure on soft tissue, which cause tissue anoxia and pressure ulcer. How we should monitor it: painful, hot spot, tightness under the cast. Cast may feel warmer, and drainage with unpleasant odor. You can see that some area of the cast color changes also. Other complication is disuse syndrome, which immobilization can cause muscle atrophy and loss of. So question: a nurse is assessing a patient who has a casted compound fracture of the femur. Which finding is a manifestation of a fat emboli? Well, altered mental status, reduced bowel sound, swelling of the toe distal to the injury, and pain with passive movement of the foot distal to the injury. What do you think? All right, let's see. So, correct answer is A. Altered mental status is an early manifestation of fat emboli. Other manifestations include dyspnea, chest pain, and hypoxemia. Reduced bowel sound is an adverse effect of opioid narcotics and can be result in constipation. So if you go back to the question, is the constipation is a adverse effect of opioid narcotics. If it's swelling of the toe distal to the injury is a manifestation of reduced circulation and can be the result of a tight cast. The nurse should elevate the extremity and apply ice. Pain with passive movement of the foot distal to the injury is an expected finding. Severe pain or pain on relief by the narcotic is a manifestation of compartment syndrome. Okay, other immobilization fixation or devices are fixation. And there are two types of fixation, external fixation and internal fixation. We had the lecture under the open reduction and internal fixation. I'm going to explain a little bit and then we're going to continue with external fixation. Just as a reminder and refreshing your memory. Open reduction refers to a visualization of a fracture through an incision in the skin, and internal fixation with plates, screw pins, rod, and prostheses as needed. If you remember, the open reduction or internal fixation was used for the hip replacement and knee replacement as well, or arthroplasty. After the bone heals, the hardware might be removed if this is internal fixing a fractured area, not replacing. So if there is and prosthesis used, it could not be removed because it's some part of the bone and the joints were removed and the prosthesis replaced in there. But in some cases, internally they fix fragments, and then after the bone heals, the hardware might be removed depending on the location and the type of hardware. Circular external fixation is a technique to promote new bone growth for malunion and non-union fracture. And what are the nursing action or nursing intervention prevent dislocation? As you remember, we talked about the hip dislocation. So it is very important. Monitor skin integrity. Make sure heels are off the bed at all times and inspect the bony prominence every shift. And what else? We can talk as a nursing intervention. After the internal fixation, observe the cast or dressing for postoperative drainage. If there was a cast applied, monitor for manifestation of fat and pulmonary embolism. Usually fat emboli occurred with long bones. So keep that in your mind. If you have a patient who had a long bone fracture, it can cause fat embolism. Provide anti-embolism stocking and a sequential compression device to prevent DVT and administer prescribed anticoagulant. Monitor the patient for pain level. And you know that as a nurse, you need to administer analgesic and antispasmodic or anti-inflammatory medication to relieve the pain. Position for comfort, and sometimes you can use ice on the surgical site. Monitor manifestation for infection, increase physical mobility as appropriate. Monitor orthostatic blood pressure when the patient gets out of the bed. For the first time, turn and reposition patient every 2 hours. Have the patient get out of the bed from the unaffected side and position the patient for comfort within restrictions that is ordered. Nutritionally support the patient and encourage increased calorie intake. Ensure the use of calcium supplement. Make sure that the small frequent meals with the snacks give it, and monitor patient for constipation. We're going to go over the complications later. So we are going to talk about the external fixation device. As you noticed in the previous slide, the picture shows an external device that is used to fix a fracture. External fixation involves the fracture immobilization using percutaneous pins and wires that are attached to a grid external frames. And it is used to treat comminuted fracture or non-union fractures with extensive soft tissue damage. The leg length discrepancies from congenital defects, it's used for that, and also it can be used for bone loss related to tumor or osteomyelitis. What are the advantages of the external fixation is immediately can stabilize the fracture. It minimizes the blood loss in comparison with internal fixation, and it allows for early ambulation. External fixation also maintained alignment of closed fracture that couldn't be maintained with cast or stent. And it permits the wound care with open fracture. So if there is an open fracture and there is a wound after the trauma, so external fixation can allow for healing the wound as well. What are the disadvantages? Usually, the first thing is risk for pin site infection or osteomyelitis, which is really time needs lengthy time to be treated, and the potential overwhelming appearance to the patient. So usually it doesn't look good. The people doesn't want to comply with this, and it can cause issues. What we should do for internal fixation, what is our action? We need to elevate the extremity, make sure they monitor neurovascular status and skin integrity. You assess for the body image and perform pin care every 8 to 12 hours, and monitor site for drainage, color, odor, and redness. So you know these signs are the sign and symptom of the infection, so you want to make sure you check for those, and expect weeping or drainage of clear fluid for the first 48 to 72 hours. Observe for manifestation of fat and pulmonary embolism, and also for preventive measures for DVT, provide anti-embolism stockings and sequential compression device to prevent deep vein thrombosis. What to teach to the patient with the external fixation is educate them for the pin care as prescribed. We need to follow the prescription of the surgeon. Clothing might need to be altered to cover the device, and if activity is restricted, perform just educate the patient for deep breathing and leg exercise and other techniques to prevent complications to immobilization. Usually, if the patient can develop the complication of pneumonia or thrombus formation. And what else? Well, take a look at the answer. Option D is the correct answer. The patient should clean the pins using a separate cotton swab on each pin to decrease the risk of cross-contamination, which cause pin site infection. The external fixation device should never be used to lift or move the affected leg. The patient should report the redness, heat, and drainage at the pin site, which can indicate infection, and the patient should clean the external fixation pins 1 to 2 times daily to remove exudate that can harbor the area. And the other device that is used to immobilize the fractured area is the traction. Traction uses a pulling force to promote and maintain alignment to an injured part of the body. The goals of traction include decreasing muscle spasm,
and pain, realignment of the bone fracture, and correcting or preventing deformities. The type of traction, amount of weight, and whether traction can be removed for nursing care must be determined to obtain its therapeutic effects. The actual results of the pulling force is somewhere between the two lines of the pole. The effect of traction are evaluated with X-ray studies and adjustments are made if necessary. Traction primarily is used as a short-term intervention until other modalities such as external or internal fixation are possible. These modalities reduce the risk of disuse syndrome and minimizes the hospital length of stay, often allowing the patient to be cared for in home setting. So, there are different types of traction, skin traction and skeletal traction. You can see different type of skin traction in your textbook. One is box extension traction, cervical head halter traction, and pelvis traction. So basically what you learn about care for skin traction mostly are similar. So it doesn't matter which type of them should be given in the exam. You need to know how to care for the patient in skin traction and skeletal traction. We're going to talk about the different traction too. This is a box extension traction. Is the most common type of the traction that is used for immobilization. So I talked about the goals of the traction, and let's see. The primary purpose of the skin traction is to decrease the muscle spasm and immobilize the extremity prior to surgery. Usually this is very temporary and maybe within 24 to 48 hours the patient would have the surgery for internal or external fixation. And as I said, the pulling force is applied by weight that are attached by rope to the patient's skin with tape, strap, boots, or cuffs. What you see in the box extension traction is boot, and tape and straps also used. What can cause this, what complication can occur upon using the traction is the same as compartment syndrome. So usually box traction are used to preoperatively for hip fracture to immobilize this in adult patients. Let me talk about skeletal traction. We talked about the skeletal traction, and for skeletal traction, screws are used and are inserted into the bone, such as the hollow traction. It can be used heavier weight, so using skeletal traction, they can use extra weights, 15 to 30 pounds. And it is used for longer traction time to realign the bone. It's not temporary like the skin traction or box traction. It provides we need to provide frequent pain site care to prevent infection. Before I go over the principle of effective tractions, I would like to talk a little bit about nursing action. I'll go later over the nursing intervention for skeletal traction. Principle of effective traction is very important to know what I should do to have an effective traction, because we said that using the traction is because to prevent from the muscle spasm or
and alignment, realignment, and pain. Now, traction must be continuous to be effective in reducing and immobilizing the fracture. So basically, anything that interrupts that continuous traction or pulling should be discouraged. It is discouraged. So that means you as a nurse need to be aware of how to handle the traction to prevent from the disruption of the traction. It should not be interrupted, never interrupted. Weights are not removed unless intermittent traction is prescribed. Any factor that might reduce the effective pull or alters the result of the line of pull must be eliminated. Patient must be in good body alignment in the center of the bed when traction is applied. So always monitor the patient alignment, body alignment in the bed during the traction application. Ropes must be unobstructed. So there are some ropes that are used. It could be knotted or not. So everything should be unobstructed. Weights must hang freely and not rest on the bed or floor. Knots in the ropes or the foot plate must not touch the pulley or the foot of the bed. Okay, preventive nursing intervention for a patient in traction. First, we need to make sure that there is proper application and maintenance of the traction. What should I monitor? So monitor for complication of skin breakdown, nerve pressure, and circulatory impairment. So always assess neurovascular status of the affected body part every hours for first 24 hours and every 4 hours after that. Maintain body alignment. Avoid lifting or removing the weights. Ensure that weights are hanging freely. And make sure that pulley ropes are free. I talked about that. Notify the provider if the patient experiences severe pain from muscle spasm and unrelieved with medication or repositioning. Move the patient in halotraction as a unit without applying pressure to the rods. Routinely monitor skin integrity and document. Use heat massage as prescribed to treat muscle spasm. Use the therapeutic touch and relaxation technique. And inspect the skin at least 3 times a day. Palpate traction tapes to assess for tenderness and assess sensation and movement. Assess pulses, color, and capillary refills and temperature of finger or toe. Assess for DVT indicators and assess for infection. Well, we are going to talk about the fracture complication. There are 2 types of complication. You can see it in your textbook, early and delayed complication. Early complication could be shock, fat embolism, compartment syndrome, VT or DVT, and PE, which is pulmonary embolism. And if you remember, the shock could be as a result of hemorrhage, fat embolism, as I said in the previous slides, that long bone, usually it occurs to the long bone fracture, right? Like a thigh and ulna and all of this. And it is rarely occurs with the small bones. The delayed complication are delayed union and non-union, avascular necrosis and reaction to internal fixation devices, complex regional pain syndrome, and heterotropic ossification. Let me see if I have anything else to talk in here.
Avascular necrosis is a death of tissue secondary to the poor perfusion and hypoxemia, commonly found in hip fracture or in fractures with displacement of a bone. Delayed union is prolongation of expected healing time for a fracture. So make sure to learn about the nursing intervention, how we can handle. So compartment syndrome manifestation. I talked about compartment syndrome by itself. That is an accumulation of the fluid and blood either in the fascia or a pressure from the outside to that fascia. So what are the signs and symptoms? Again, 5 P's in the fracture: pain, paresthesia, paralysis, pallor, pulselessness, which you as a nurse want to monitor this extremity every hour for first 24 hours and every 1 to 4 hours after that for at least 72 hours, and assess the neurovascular status frequently, notify the provider when compartment syndrome is suspected. Very important. So you want to make sure assessing for those 5 P's, and the first one, as I said before, was pain. So you want really to make sure unrelieved pain with the medication, with narcotic, must be reported as soon as possible. And in some cases, if there is pressure because of the constrictive dressing or a bandage, so make sure to loosen them until the provider get to patient and start the treatment. So basically, I would like to talk about the nursing action. Nurse should maintain the patient on bed rest. Prevention includes immobilization of the fracture of the long bones and minimal manipulation during turning if immobilization procedure has not yet been performed. The treatment of fat embolism includes oxygen for respiratory compromise, corticosteroids for cerebral edema, and vasopressor and fluid replacement for shock, and as well as pain and anti-anxiety medication as needed. We talked about the venous thromboembolism and monitoring for thromboembolism and treatment of that. I would like to talk about a little bit about avascular necrosis, which result from the circulatory compromise and that occurs after a fracture. Blood flow is disrupted to the fracture site, and the resulting ischemia leads to tissue or bone necrosis. Commonly, it is found in hip fracture or in fractures with displacement of a bone. Risk factors for developing avascular necrosis includes long-term corticosteroid use, radiation therapy, rheumatoid arthritis, and sickle cell disease. Replacement of damaged bone with a bone graft or prosthetic replacement can be necessary. Well, I think I covered all complication and nursing management. For each complication, I would like to wish you a good luck with this semester, and I'm sure you will receive news about the tests and exams. Please make sure to check the Blackboard announcement for any updates, and I wish you guys good luck with everything. I will voice over for my next lecture as well, HIV and hepatitis. Hope to see you soon all, and be safe. Bye.